Psychiatry Bootcamp, and today's topic is functional neurological disorders. Functional neurological disorders are one of the most fascinating and misunderstood areas in all of medicine and have been recently made famous by the hit show Never Have I Ever, which, by the way, has a 94% on Rotten Tomatoes and is 100% certified fresh. By me personally, highly recommend, but I digress. We are going to jump right in today with my expert guest, Dr. Caitlin Adams, who will blow you away with her clear and concise way of demystifying this topic. She really gets straight to the point and explains the topic in a way that will be helpful for doctors, for healthcare workers of all stripes, patients, family members of patients, and the curious public. Dr. Adams, welcome to Psychiatry Bootcamp, and I will ask you to introduce yourself to our audience.
Sure. So my name is Caitlin Adams. I'm a CL psychiatrist that's practicing at Mass General in Boston, Massachusetts.
Dr. Adams, could you briefly define the term functional neurological disorder for us?
Sure, certainly. So functional neurological disorder describes a set of, I would say, diagnoses that previously was under a different diagnostic name. So I think it's helpful when we talk about functional neurological disorder to give it a little historical context. Before it was called functional neurological disorder, it was previously called conversion disorder in the DSM-4. Prior to that, it was called hysteria. So hysteria was a pretty old term, problematic for many reasons, and we could spend an entire podcast talking about why that was a problematic term. But this is one that Charcot initially had coined in the early 19th century, and then Freud kind of took it from there and believed that these neurological symptoms were actually the result of some unresolved conflict, some unconscious conflict. Again, problematic for many reasons. They believed it happened only in women, and that it was a psychological disorder that was presenting itself with neurological symptoms. When we moved to conversion disorder in the DSM-4, the effort there was to perhaps get rid of that stigma. Conversion disorder, however, did have its own issues. So the idea here is that psychological symptoms are converting themselves into neurological symptoms. And we will talk about the difference between a rule in and a rule out diagnosis. But conversion disorder was a rule out diagnosis, kind of a wastebasket diagnosis of we don't really know what's going on, but everything looks normal. So we're going to put you into this diagnosis. Functional neurological disorder was an effort in the DSM-5 to try to, again, further reduce stigma. We use the term functional in many other specialties of medicine. Functional abdominal pain, functional cardiac pain. The idea here is that you have disordered functioning of your nervous system, and that's what causes these symptoms. So for many reasons, I think the term FND or functional neurological disorder hopefully has shifted away from this thought of this is a psychiatric diagnosis and nothing is wrong with you. You need to go talk to a psychiatrist only, but really given us more context. When explaining it to patients, I think it's helpful, right? Because patients don't care about what they don't have. They want to know what they do have. And so functional neurological disorder is helpful because you can say, I know what you have, and you have disordered functioning of your nervous system, and hopefully we can retrain your brain how to communicate with your body.
So starting from hysteria, the kind of original, and that goes back, I think, to antiquity, basically, the phrase hysteria, and then moving into conversion disorder and the sort of psychodynamic understanding of things. I think the field has evolved to adopting the term functional neurological disorder. I know, at least in my training, that is almost exclusively what I have seen used, but of course it does take time for the field to change. So Dr. Adams, do you feel comfortable then saying, for our international audience that functional neurological disorders are in fact not caused by a wandering uterus?
Correct. Yes, I would feel confident agreeing with you there.
Okay, thank you for clearing that up for us. So that's how the term has evolved over time. I think that the next question that needs to be asked right up front, and in practice there's a lot of misunderstanding about this because it's difficult to understand, frankly, is are symptoms of functional neurological disorders real or are they feigned, right? So phrased differently, are patients with an FND able to control the symptoms but choosing not to control them to gain attention, occupy the sick role, satisfy some other need, satisfy some secondary gain? Or are the symptoms of a functional neurological disorder as confusing and uncontrollable to the patient as to anyone else?
Yeah, so the latter, I think, was what most patients would say, and what we believe as clinicians treating this. There's been some studies looking at fMRI research comparing people who are feigning things, like feigning a functional gait disorder, feigning a tremor, and they compare patients in like a go, no go task. So asking them either to move or to not move, and that will give us data and compare them to patients with FND. And there are real changes. So this is not feigning. It is not malingering. These symptoms are very real to the patient. They feel very uncontrollable to the patient. But hopefully over the course of treatment, you can get them to, have strategies to feel like they can better control these symptoms.
Okay, so we're seeing MRI changes which tell us that there is something. This is interesting to me because I feel like when we talk, FNDs are right at that razor's edge between psychiatry and neurology. And the traditional way we kind of split that hair is there a quote unquote organic pathology? If so, go to neurology. If there's no organic pathology, then go to psychiatry. But I mean, we would have to consider changes in MRI to be an organic sign of brain dysfunction. So you feel like that has really, once we found those objective changes, that has really advanced the field away from saying, there's really no way to say that these patients would be faking this, controlling this, if we know for a fact that there's these objective changes. Is that a fair summary?
Yeah, and it's a complicated picture because when we even talk to patients about this, like, do you believe me? Do you think that I'm making this up? We can say, well, this is what the literature shows us. And the fMRI studies, which are only really used right now in research, like we don't do an fMRI study to diagnose FND. So it's tough, right? Like this patient will come in and say, my MRI is normal. And so I'll tell them like, yes, that split image of your brain in that moment, I can't point to a specific area like I would if you had a stroke and said, this is the cause of your symptoms. But it's more about this kind of growing body of literature and research that's telling us, well, maybe your part of your brain that controls movement is has too strong of connections to your amygdala or other areas of your brain where it shouldn't, and things are activating in a way that it shouldn't. And so this is, again, where I think some patients would like to see an image and say, okay, there is an issue and I can point to it, and that explains why I'm having these symptoms. But it's a little bit more nuanced than that and more about communication, these pathways between different areas of your brain that might be overvalued or undervalued in a particular patient.
Totally appreciate your point that just because we have epidemiological studies showing that in general, patients who meet these criteria have these findings, it doesn't necessarily mean that the patient right in front of me has these exact findings. And I feel like one metaphor that I often hear is software versus hardware. And you're kind of telling me it's more of a software or more of a connectivity problem.
Yeah, and it's an interesting. We use that analogy all the time of a computer. I think it's easy for patients to understand. Like, okay, your mouse looks fine, your keyboard looks fine, the monitor is working, but there's some sort of disconnect, and so maybe you just need a software update. But it's interesting. The more fMRI studies that come out, like maybe it's a more complicated picture of there is something happening in the brain, and maybe at some point we will have the skills to be able to pick up on that. But for right now, we don't.
How common are functional neurological disorders in clinical practice?
Yeah, great question. They are very common and they are probably very underdiagnosed still, even though we're learning more about FND. And I think it's being incorporated into training, at least in the United States, quite often, which is nice. So, a recent systematic review by one of my colleagues, Sarah Finkelstein, in 2025, found that the incident is 10 to 22 per 100,000. And just to give you some context, because how common is that? So 10 to 20 over 100,000 per 100,000. Parkinson's, the incidence of Parkinson's is 18 per 100,000. MS is 2 per 100,000, and ALS is 1.6 per 100,000. So this is quite common. And those numbers are probably underestimating what's actually happening because there's a lot of patients who do go undiagnosed. And so some studies have said that, it's probably the second most common reason to see an outpatient neurologist, second only after headache. And this is quite common. And we're seeing this in the emergency room. We're seeing this in outpatient. We're seeing it on inpatient CL services. It's happening and very, very common.
The next question is one that's kind of special to me because this is one of the few soapboxes that I will get on with my residents and medical students. And it's just something that I think there's still maybe some controversy about just because it's evolved so rapidly in the last several years. So where we're at now in 2025, would you consider functional neurological disorder to be a diagnosis of exclusion?
I think that's a great question. And conversion disorder, if you look at the DSM-4 criteria, it was a diagnosis of exclusion. It is now moved, and this is one of the updates, and I think helpful updates for FND. It is now a rule-in diagnosis. So we can do a physical exam, a very specific neurological exam, and look for clinical rule-in signs, which we can talk about. But these would increase our confidence that what we are seeing is actually FND. I think this is helpful as a provider. It doesn't feel good to give patients these exclusionary of like, we think everything is normal, your MRI looks okay, your EEG is negative, so I think that you have this diagnosis, because it leaves the question of what am I missing? And I think patients don't like to receive that diagnosis either, right? Thinking, well, surely I'm just going to keep seeking second medical opinions and coming to the ER when I'm symptomatic because nobody really knows what I have. They're just telling me that I don't have this cluster of symptoms and I must fall into this diagnosis. So I think it's helpful for both patients and for providers now that it is this rule-in diagnosis with actual clinical rule-in signs.
I think in order to talk about exactly the signs that we're looking for to rule in this diagnosis, we first need to talk about maybe the most common types of functional neurological disorders. Could you walk me through the most common different ways that this presents?
Yeah, certainly. And so it can present in a whole bevy of different ways, but we sometimes will split it into a functional motor disorder. So this would be issues with walking, a functional gait disorder, a functional tremor, a functional dystonia. And then there's functional seizures, which kind of fall into its own little class there. And then people will have kind of functional sensory symptoms. So there's triple PD, which is a positional vertigo type of, I'm trying to think what the 3PD stands for, but it's a functional dizziness that is chronic and it lasts, and it's often stimulated or worsened by like complex carpets on the floor, or complex environmental stimuli. So I like to kind of put them in those buckets, and treatment will differ depending on what you're presenting with, right? So if you're presenting with a functional motor disorder, we're probably going to start by referring you to physical therapy, try to retrain those movements initially, versus if you have functional seizures, maybe we need to change your seizure meds or refer you out to CBT right away. So the treatment will differ, I think, based on what functional neurological disorder symptoms patients are presenting with.
So most commonly, if it's going to be a motor type functional neurological disorder, we're looking at seizure-like episodes, attacks or seizures. We're looking at weakness, lower extremity weakness, functional tremors, gait disturbances, etc. So in thinking then, let's focus strictly on the motor subtype of functional neurological disorders. What specific signs are we looking for in order to rule in this diagnosis?
Yeah, so you're looking for reversibility and variability. So, for example, in a tremor, and there's great videos on YouTube of looking for these clinical rule-in signs. So, if you have a patient presenting with a tremor and there's variability to the tremor, or you can entrain the tremor, so you might ask the patient to put out their arms in an outstretched position, and then you ask them to actually touch their finger to their thumb and like tap their finger to their thumb, and then their tremor on the other side will actually take on the cadence of the tapping. So that's called tremor entrainment. That would be a clinical rule-in sign. Hoover sign is the most commonly talked about. So this is a measure of functional weakness. When you go to test the weak leg, it will look weak. When you go to test the strong leg, it will be strong. And then when you go to test both legs simultaneously, that weak leg will actually show movement and regain strength. And so it's reversibility of that weakness. So the Hoover sign, again, is the most common. If you're doing it in a seated position, you can do something very similar. The hip abductor sign, that's another clinical rule-in sign. What's interesting is a lot of patients with things like functional seizures, which are diagnosed with, the gold standard would be a video EEG that captured a spell. There was no change to the EEG diagnostically. Functional seizure, you can feel pretty confident in that. But a lot of patients with functional seizures will also have a Hoover sign, a hip abductor sign, a lot of things like that. For functional sensory symptoms, you're also thinking about kind of how the body should be responding, right? So if a patient comes in and says, I have splitting of the midline, I can't feel my whole left side of the body, that's a functional sensory symptom. That's a clinical rule-in sign there, because that's not what we know about how kind of dermatomal patterns work, how our sensory system should work.
So those are all very specific clinical signs, meaning we can objectively look for those. What about just the history itself? Is there ever a time when the history provided by the patient is so strongly suggested of a functional neurological disorder that we can rule in a functional neurological disorder based strictly on the history alone?
So that's a great question. A lot of patients will have things that pop up, abrupt onset or paroxysmal symptoms, like this happens and the symptoms come on very suddenly, and then I present to the ER. However, we in our clinic would say it's not FND unless you have a clinical rule and sign. So you need
Sign.
to have something that you can produce on physical exam to confirm that it is in fact a functional neurological disorder.
So the case that I'm thinking of, one of the more recent cases that I saw, it was mind-bogglingly straightforward to me. It was a patient who had a bit of kind of alexithymia, really wasn't able to speak much about their internal world, mentalize their feelings, etc. And they had abrupt onset lower extremity weakness after a major psychological, traumatic, stressful event. And in calling collateral, this patient, young adult patient who lived at home, the patient's mother said, I'm just sure that this is all just stress related. I'm sure that stress broke his back, right? He says his back is broken, but I just know that it's strictly stress. And I thought, I just couldn't imagine a history that would be more consistent with the functional neurological disorder. I had never heard, usually it's a lot more complicated than that. But I hear you loud and clear that even then, my clinical suspicion might be extremely high, and I might
Correct.
look really hard for all of these different signs and symptoms. But unless I can objectively find a sign, then I cannot firmly rule in the diagnosis. Is that correct?
Correct. Yes.
So let's say we have taken a history consistent with an FND, we've performed an exam, and we feel that we have ruled in the diagnosis using the Hoover sign, using tremor entrainment, or captured spell on video EEG being the gold standard for functional neurological disorder with attacks or seizures. Let's say we feel we've ruled in the diagnosis. If I'm a patient on your CL service, how would you explain to me that I have a functional neurological disorder? How would you make the diagnosis?
Yeah. And I think, delivery of the diagnosis is the first step in treatment. Like if delivery goes well, I think the next subsequent steps are going to go well. So I think it's important that we think through this and we try to plan this very well. Often it will play out on an inpatient CL service where neurology has completed their workup. They feel like it's FND. They will consult psychiatry, and the patient happens to be like discharging hours later or the next day. So I think it's worth having a conversation with neurology. Can you keep the patient a little bit longer? We need a little bit of time to deliver the diagnosis to set up the aftercare plan. Because I think this handoff, if it goes well, the patient's going to have a better outcome. So I think that's step one. I also think it's important, and this is inpatient CL or even an outpatient kind of CL type psychiatric embedded in neurology model of care, that neurology stays on board. I think if neurology signs off, it signals to the patient, oh, this is a psychiatric problem, and they must think I'm crazy or it's all in my head. So if you can go with neurology, this would be ideal, and you both explain the diagnosis together, I think that's really important. Critical steps. One, the diagnosis has a name. This is what it's called. We know that this is what it is. I think explaining to the patients, we are confident that this is the diagnosis because of XYZ. So you can show them the clinical rule and sign on physical exam. You can talk to them about what in their history might have raised the flag that led you kind of down this pathway, and then you found the clinical rule and sign. Talking about reversibility. So for a lot of patients, these symptoms can improve. You can get better with treatment. So setting the stage that they can get better. And then I think for patients, it's helpful for them to know, why are you referring them to XYZ, right? So if you're referring them to physical therapy, why is that the case? What's going to happen behind the curtain? If you're referring them to occupational therapy. So for example, you mentioned that you have a lot of sensory overload. If you go to the grocery store, there's a lot of stimuli and the lights are bright and it's loud and there's carts flying at you, et cetera, and that might trigger symptoms. So we're going to refer you to occupational therapy to help with those sensory symptoms. I think sometimes patients, will see neurology get diagnosed with FND and then they're handed a referral to psychiatry and the diagnosis isn't explained and the patients are like, why is this happening? So things like talk therapy, CBT, cognitive behavioral therapy, which is the most commonly used flavor of psychotherapy that we recommend in patients with FND. I think it's important to explain why. A lot of patients, as you mentioned, the term alexithymia comes up a lot. Sometimes these patients can't describe their internal state. You'll give them a sheet of what emotion are you feeling, and they can't identify with any emotion. So they'll be like, why are you sending me to psychotherapy? So I think it's helpful to have that conversation. But on an inpatient unit, when the consult comes through, I will do my own neurological exam. I will ask them of a very thorough history, especially a neuropsychiatric review of systems. We call this draining the symptoms dry. You want to make sure that you've hit everything that could possibly come up so that when you go to deliver the diagnosis, they're not actually interrupting you saying, oh, I actually also forgot to mention I have headaches or irritable bowel syndrome or Sometimes I get dizzy. You want all of that to come up before you deliver the diagnosis. And then after you deliver the diagnosis, education is so important. So I will often print things for patients from a website, neurosymptoms.org. I will ask them to read the information. I will come back the next day and say, what questions do you have for me, to make sure that we've kind of thought this through. But I think education is key, right? So explaining to them what this is, why we're confident that this is what it is, and then what's going to happen in the next phase of treatment.
Anecdotally, I have seen this done well, and I've seen this done very poorly. And again, just speaking anecdotally, when it's done well, the outcome is drastically different. So you just dumped an unbelievable amount of wisdom on us. So I'm going to review just a couple of things you said. One is you're getting to the liaising side of consultation liaison psychiatry, right? Consultation liaison psychiatry is politics. So if we are asking our neurological colleagues for their expertise, we are asking them to help us to treat the patient. And, this is really hard on consult sometimes because we don't, kind of own the patient, right? It's not our bed. So we're not making the ultimate discharge or not discharge decision. And so it can feel like we're a bit hamstrung. So making sure we have good relationships with our colleagues, making sure that we are planning this with our colleagues before going to the patient and interfacing with the patient to kind of get ahead of any resistance or negative outcomes that could occur from that. I am not a Harry Potter guy. My roommates in college sat me down and made me watch all of the Harry Potter movies. So I've seen them, but I'm not like a big Harry Potter guy. But my psychotherapy supervisor in residency talked about the name Voldemort and how in Harry Potter, a lot of Voldemort's power comes from the fact that you can't even say his name, right? And then once his name is said and you can actually name what this force is, you can start to develop a plan as to how you're going to deal with it. And that's what you're talking about here. These are not confusing, unexplained symptoms that nobody has ever seen before. We have a diagnosis for this. We have a name for this. We have an entire website dedicated to it. And there's a whole population of patients that have experienced the same things and have gotten better, and we can plug you into that. So giving it a name and not skirting around the diagnosis or thinking, I better just explain this in some vague terms so that I don't upset the patient is a huge step. And then I think it's also important, psychoeducation is the first step in treatment in this case as well. So showing the patient what the objective signs are, and then also as we're talking about our plan, we're putting it in the patient's individual context and telling them how these individual steps of the plan, whether it's PT, OT, psychotherapy, medications, etc., apply specifically to them. This was the last thing. One of my constant kind of pearls that I'm trying to teach on the CL service is how to have difficult conversations. And my biggest tip for that is you have to let the other person lead, right? In any difficult conversation, you want the other person to lead that encounter because they're going to tell you what's important to them and they're going to give you the answers as to how to navigate this conversation. So when you're talking about draining the symptoms dry, that's what you're talking about, right? Give me your full history. Tell me everything that worries you. And then I know how I'm going to tailor this conversation so that it goes in a productive way as opposed to a really counterproductive way. And I think with a lot of these patients, a lot of their interactions with healthcare professionals to this point have been counterproductive. So we need to be extra aware of that.
Yeah, I agree with that. And a lot of patients will say, I've felt so unheard. I feel like I've gone to a specialist and they've just told me, you don't have this, send me on my way. And so I think that the draining the symptoms dry is helpful because then they feel like, oh, wow, you have heard me. You do know what I'm talking about.
Do you have any advice for clinicians regarding specific patient reluctance or doubt about the FND diagnosis?
Yeah, so this can be a pitfall, right? So if you have a patient that comes in and you explain FND, you give them education, you follow up with them and they say, I really don't know about this and I think I have chronic Lyme or I think it's XYZ. In our clinic, what we will do is we will say, okay, like let me go over, I'm going to review why I think it's this and why I'm confident it's this, but then go seek out that second medical. Like if you are confident you think it's chronic Lyme, then go see the chronic Lyme expert, come back and we can talk about it further. But I think that if you're trying to force the diagnosis on the patient, I think there has to be a certain amount of buy-in or the treatment's not going to go well. The next steps are not going to go well. So I'm often asking patients, we talked about FND. What questions do you have? Are you confident in the diagnosis? Do you have any reservations about this? And having that conversation in the room, I think, can be helpful.
With functional neurological disorders, we often talk about the predisposing, precipitating, and perpetuating factors, right? We do this with delirium as well. If we're doing good, thorough case formulations, we're using some number of P's model usually that kind of mirrors this. Could you talk to us about the predisposing factors for functional neurological disorder?
Yeah, certainly. And I think this is a nice way of framing FND. It's bread and butter to psychiatry, right? This kind of thinking about a biopsychosocial formulation. How do we think about the patient? I think it's helpful for neurologists to look at patients in this way too, because there are factors that they might be missing. In terms of predisposing factors, it is not as clear cut as, conversion disorder was. You had to have some sort of trauma, some traumatic experience that happened prior to the onset of symptoms or in close correlation. That's gone. That's no longer present in the criteria. That being said, a history of trauma will increase your risk of having FND. A history of psychiatric symptoms, early life dysfunction, like that will all increase your risk. It does not need to be present, but it can be present. So those are some predisposing factors that could be there.
What about precipitating factors? What do the proximal precipitants usually look like for FND?
Yeah, good question. So we do have patients. I have one patient that comes to mind that has functional seizures. She was in a car accident, woke up the next day and started having functional seizures. So could we argue that that was a precipitating event? Yes, probably. Is it as clear cut as that car accident caused her FND? No, I think we're in the weeds there. We cannot definitively say X caused FND. But other things that might pop up. They might go through some traumatic event. We have a lot of patients who are working and they have something happen at work, and then they have the onset of a functional gait disorder or a functional weakness. So any sort of like acute injury, like pain, maybe they broke a bone and then they started having FND, or anything that's kind of an acute stressor can be a precipitating factor for FND.
I'm hearing that it's no longer necessarily part of the diagnostic criteria, but clinically speaking, we often can find something that is leading to the stress that might be sort of leading to these symptoms.
Uh-huh.
And what about
Yeah.
perpetuating factors? What types of things prevent these patients from getting better?
Yeah, so there's a ton of perpetuating factors, and this is what we're trying to tease out, especially kind of when you're seeing these patients longitudinally, like what's keeping them stuck. One that often pops up is pain. So if patients have 10 out of 10 pain, the FND treatment, I think, is not going to work. You're going to have to go after the pain before you dig into the FND symptoms. Other things that can pop up, litigation. So if patients are suing their work or they're filing for disability, that can sometimes be a perpetuating factor, which we think about there, like even playing an unconscious sick role, right? Like if I get better and I'm not going to get on disability, we sometimes wonder that. Other perpetuating factors, we mentioned, like if they don't accept the diagnosis, they're not going to engage in treatment, they're not going to get better. So if the patient's coming to clinic and saying, I don't really know about this FND diagnosis, I think it's these other things, then that you're not going to get anywhere with treatment. If patients, if they're having like a lot of overload, so we'll oftentimes ask them, how are things going? And if they come in and say, oh, wow, my job is really busy and I've got young children and I don't really have time for myself and I'm not getting enough sleep, I can't eat enough, I'm not caring for myself. That can be another thing that you can intervene there. But it's important to kind of tease out, like, how are things going? If you're feeling overloaded in your life, we need to do something different. So that can be another common perpetuating factor.
One thing that's coming across clearly from you is that we're definitely meeting these patients right where they're at. So when patients are not accepting of the diagnosis, when patients, even if we have tried to drain the symptoms, what was that phrase you used? Drain
the symptoms dry.
Drain the symptoms dry. There might be other things that come up, but it sounds like you're never pointing to your diploma on the wall and simply saying like, well, this is just what it is. So you can take it or you can not take it. You are welcoming patients to use, do their own research, seek a second opinion, but then you're waiting with open arms and evidence-based treatment for if that patient does decide to engage in the treatment that you're offering.
Yeah, exactly. And all throughout treatment, we talk a lot in our clinic about the patient needs to be a catalyst in their own treatment. So you're trying to get the patient curious about their own symptoms and what are triggers and how could we mitigate these triggers and what could we be doing. And so it is similar in many ways to being a psychotherapist in the moment in this like outpatient, even if it's a med management appointment, of like, how do we mobilize you? You need to be curious about your symptoms and I'm here to help you on that journey, because that's how we're going to figure out how to get you better.
And it speaks to how treatment for this is different than treatment for a lot of other problems in all of medicine, in that there is no pill for this, period, really, right? You can treat comorbid disorders, but there's no FDA-approved treatment and not even really any promising studies on specific treatments for functional neurological disorders. There's no surgery for this. You can't simply be put to sleep and someone operates on your body and then you're all better. The treatment for this is extremely active. You have to be actively engaged in the process. And so unless you're able to give that patient a feeling of self-efficacy and have them really engage on their own behalf to get better, I guess what I'm saying is pushing the patient and forcing the patient is counterproductive because it really is the patient that needs to actively engage in the treatment. You can't simply push the patient along for treatment of FNDs.
Definitely. And the director of our clinic will give the example of like, if I have a rash and I use a cream, this is very different, right? Like you use the cream for 7 days, your symptoms are gone, you move on with your life versus this, you have to actively engage. You have to be curious or you're not going to get better.
Psychiatry Bootcamp is brought to you by Simple Practice. Simple Practice saves you time so you can focus on spending that time with the patient and not on writing notes. Simple Practice now has an AI-powered note writing tool integrated within the health record so that it's a true all-in-one EHR. Simple Practice is HIPAA compliant, it's high-trust compliant, and you'll also love the PDMP checks integrated within the portal and the easy-to-use lab order templates. Simple Practice saves you time so you can focus on what matters most. For a 30-day free trial of AI Note Taker and a PBC exclusive 7-day free trial and 50% off 4 months for Simple Practice EHR, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Psychiatry Bootcamp is brought to you by Beat the Boards. Listen, Beat the Boards is offering us a ridiculous deal. Bootcamp listeners now get free access to over 4,400 USMLE Step 2 questions and over 4,500 questions for Step 3. This is not a discount. It's completely free. Don't miss this opportunity. Go to beattheboards.com/bootcamp to get started today. I used Beat the Boards to study for my own board exams, and I found them to really reflect the real exam and make the exam a breeze. Give it a try. beattheboards.com/bootcamp. Let's pretend that I'm a patient on your CL service. You have made the diagnosis of functional neurological disorder, and maybe I'm kind of intermittently accepting of the diagnosis, probably as accepting as most patients are. And the next question is, okay, so if this is the diagnosis, how do I get better?
Yeah, good question. So we would look at the specific patient and then refer them out to colleagues. And this would be if you have a patient with a functional motor disorder, you might think about starting with physical therapy. A good example would be if they have a functional gait disorder and they can't walk and maybe they're in a wheelchair and they're scared they're going to fall, you would send them to physical therapy, where if we pull back the curtain, like what is happening, what makes physical therapy for FND different than like post-stroke physical therapy or an ortho physical therapy. And the whole goal of physical therapy for FND is restoration of normal movement. So they're going to get these patients up out of the wheelchair. They're going to use different techniques. Distraction is one of them. So I'm going to have you walk, and while you're walking, I'm going to have you say the days of the week backwards. Or while you're walking backwards, I'm going to have you hum a song or sing a song. And so you want to, I would say, demonstrate to yourself that this is reversible as the clinician and the physical therapist, but you also want to show it to the patient. Look, you were able to walk when we distracted you. So now we're going to keep doing this. Repetition. We want to restore your normal. We want you to be able to do activities of daily living, including walking. So we're going to keep doing it. And then I think the balance here is we spend a lot of time talking about pacing in the world of FND. So not pushing too hard, right? Like we want to progress symptoms. We want to get you walking more. But if you go out and you try to run a marathon tomorrow, you're going to be debilitated for a few days versus if we slowly build you up and practice and practice and practice while pacing, again, that balance, then you're going to get better. So for some patients, they might start with physical therapy. I touched on occupational therapy a little bit earlier, which can be helpful for people, especially if they have kind of this sensory overload. So if they come in and say, my triggers are, I can't leave my house, the sun is too bright, or something is too noisy. And occupational therapy, similarly, will try to kind of get patients doing, again, these activities of daily living, get them back to their normal life, but giving them coping strategies. So grounding techniques are often used for patients when they're feeling kind of this sensory overload. Can you use a fidget spinner, or can you use, I don't know, those like, stress balls or whatever it might be, hot, cold. Can you put a cold compress on your neck, and that might distract you away from your symptoms and get you feeling better and get out there. Other things that we refer patients to, so psychotherapy we commonly recommend psychotherapy. CBT has been the most studied in patients with FND. It's been proven to be effective. So the CODES trial was a big study looking at a CBT specific model and interestingly, self-guided CBT. So they gave patients with functional seizures specifically a workbook. They sent them on their own. They would do this self-guided CBT. And then the outcomes there, they looked at number of seizures, which did not go down. That was the primary outcome measure there. But then at the secondary outcomes in terms of like quality of life, depression, anxiety, seizure severity, impact of seizures on their life, all of those things improved. So patients, we often refer them to CBT. The CBT, anyone can, like CBT is a manualized treatment. So oftentimes patients will say, I can only see your CBT therapist. I can't see anyone in the community, which is not true. So I spent a lot of my time picking up the phone, calling physical therapists, occupational therapists, CBT therapists in the community and saying, you can do this. Here's some resources. This is the workbook that we use. I would say that the CBT is slightly modified, that it doesn't come out of the gate talking about feelings, emotions, behaviors initially. It's going to talk about the neurological system, the nervous system, our flight or fight nervous system, the adrenergic nervous system, and then it pivots later on into the mood symptoms, emotion symptoms, because again, these patients sometimes struggle to identify with that. And they're also presenting, I like to start with, like, what are you coming to clinic for? What is the consult for? Oh, it's for a neurological symptom. Let's start there, and then we can pivot to what else we think is going on, because that's what the patients want to talk about. But treatment will, back to treatment, treatment will depend on a specific patient and where you think they would benefit next. I try not to overload patients with too many appointments, right? So I don't want to say, we're going to refer you to PT, OT, CBT all at once, and you're going to have all of these appointments. So we sometimes will start with one. And then we are fortunate in our clinic that our PT and our OT teams, like, this is what they see day in and day out. So then they will sometimes reflect it back to us being like, okay, I think this person could actually benefit from a referral to pain management because that's coming up. Or they could, at this point, they're ready for CBT. Or at this point, can we expand physical therapy to also include occupational therapy? So having that communication where we're all talking about what's happening, what's holding the patient back, and where do we go next is helpful.
So this is a disorder where people are overwhelmed by the stressors in their lives, by the emotions, and it's coming out in physical symptomatology. And one thing I'm hearing from you is it's important not to make that worse. So it's important that the encounter with you makes them feel like this is something that they can manage and not something where, great, now not only can I not walk, I also have 4 appointments in the next week and I don't know how I'm going to get there and I don't know how I'm going to pay for it, right? So you're kind of starting small in that way, it's kind of bite-sized approach to make sure the patient feels like they have some success experiences and make sure we're kind of right-sizing it so they're reaching for something that is not completely out of their grasp. So if I'm hearing you correctly, it depends really on the type of functional neurological disorder and then also other individual patient factors. But for something like a gait disorder, you might start with just PT alone then, right? You might do psychoeducation, and especially if the patient really buys into that and says, you know what, that makes perfect sense to me. PT alone may be sufficient. And then you're making sure they're following up outpatient with, I guess, in our case, with psychiatry, probably with psychiatry and neurology.
Yeah, and this is where the clinic structures. It's interesting to talk to people in different F&D units across the country because we're all doing it a little bit different. And I think it's kind of based on resources and what you have. And so we are fortunate that we have a robust, like we have an OT that's obviously, she sees F&D patients all day, where sometimes you might not have that in other places. But again, I think there's a misconception that F&D is very mysterious, as you had mentioned. Like, I agree with you there that people are afraid of it. They don't know what to do with it, clinicians, patients alike. But I think it's not rocket science. Like, you can understand this. And if you are doing OT in the community, you can do OT with a patient with F&D. And in fact, I will often tell patients, they'll say like, oh, my therapist doesn't know what F&D is. And it's like, well, they're probably seeing F&D. They just don't recognize it as such. So this is actually doing them a service, not only to see the patient in front of you, but also patients down the road.
For sure. That's beautiful. And yeah, I think patients do like to feel like they're being helpful to, I mean, anyone likes to feel like they're being helpful. So if you feel like you're being helpful to a professional, you're kind of teaching them something, you're showing them that patients like me can get better. I could see where that'd be a really complicated transference, countertransference dynamic, but could actually help the patient ultimately see better outcomes. What about, did I overspeak earlier when I said that there are no medications for functional neurological disorder? Probably a little bit. What do you see as the role of medications in treating functional neurological disorder?
Yep. So good question. I spend most of my time in med management appointments actually weaning patients with F&D off medications, because a lot of times they will have seen multiple people and they've been prescribed this like cornucopia of medications that then are causing side effects. Patients with FND are more sensitive to side effects than the general population. So this is a lot of times we're using much lower doses of medications, or the medications I choose are different. So if a patient, for example, if you're working closely with epilepsy and they're on a ton of anti-seizure medications and we're confident that this is functional seizures, then you can start to wean those medications off. I will tell patients there is no medication that targets directly the FND, but if you're coming in and you're also having depression and anxiety symptoms, then maybe we use an antidepressant there. Or if you're not sleeping well, maybe we use a short-term sleeping medication or get you into a sleep study. So I'm constantly revisiting things with patients. I ask at every appointment about their sleep. I ask about cognition. I ask about pain, and I ask about fatigue. And so if one of those is popping up, I think we need to do a deeper dive of like, your fatigue is a 10 out of 10. Okay, talk to me about your mood. What are you doing during the day? What's your day structure? And if they're like, oof, man, my interest level is low and I'm feeling really depressed, we need to go after an antidepressant. So we can treat, I would say, maybe some perpetuating factors with medications, and that will improve the FND if it's a trigger. But there is no medication that we're like, oof, every patient with FND gets started on this combination of psychotropics and they all get better. Unfortunately, that does not exist.
The treatment model is reminding me a lot of delirium, I have to say. I didn't clock that until this conversation. Maybe it's because it's the same folks treating all this, but between the predisposing and precipitating factors, and then the, medications can treat specific neuropsychiatric disturbances, but to treat the functional neurological disorder itself, we need a different sort of therapy. It's a very similar model. Do you have any advice for clinicians in dealing with a situation where functional neurological disorder is a recurrent issue? So, I talked about the one case that I felt was very straightforward, and that patient did get better very rapidly. But I've also seen several cases where a patient does not seem to get better rapidly, is readmitted to the hospital several times, and maybe the battery of tests is run several times, and they just don't seem to be getting better. Some would call this treatment resistance. What advice do you have for clinicians in working with a patient like that?
Yeah, it's tough. And, we see a lot of patients who do fall in that category. I think there are some patients who get better even with delivery of diagnosis. I would say that's the exception. That's very few, but that happens, that patients get better very quickly. I think I often am talking to patients about goals. What would be a good outcome for you? And maybe it's not going exactly back to the way that you were functioning before, but if we can get you to a place where you're able to walk 90% of the time, where your seizures are happening less frequently, and when they happen, they're less severe and you feel like you have more control, I think that's a positive outcome. So I will tell the patients, like, what do you think is a positive outcome? What goal can you set that's achievable that we can get to? When patients are treatment refractory, I think it's important, one, to come back to like the drawing board. Is the diagnosis correct? One. Two, is FND the main issue, right? So if the patient has, again, 10 out of 10 pain, like, I don't think it matters if, like, we're not going to get to the FND. It doesn't matter. And that might be why they're treatment refractory. Another thing that often pops up is the treatment that's happening actually targeting the FND. So if a patient with a functional gait disorder goes to PT and, I don't know, they have a spasm and the physical therapist gets nervous and then treatment is only happening in a wheelchair, like, that patient's not going to get walking again. So I think having that dialogue of this interdisciplinary team of what is actually happening at PT and OT, because sometimes the patients aren't getting better and you call the physical therapist and they were like, I don't know, I panicked. And so we're just doing finger exercises. Like, that's not going to get the patient walking. So I think there are reasons, sometimes there are clear reasons why the patient isn't getting better. But I also think that there is a cohort of patients with FND who are unfortunately just treatment resistant.
So just good medicine in general, right? Patient not getting better, reevaluate the diagnosis, make sure I have it 100% correct, and then check for the fidelity of the treatments. Just because I've ordered something or I think something's happening, is the patient actually going to physical therapy? Is the physical therapy actually targeting the functional neurological disorder? Et cetera, et cetera. Same could be said for medications for comorbid disorders, right? The medication's not helping because the patient's actually not taking it because they couldn't afford it or something. So I think that makes a lot of sense. And then I think what you're implying there too is being realistic with some patients are not, I think we have a hard time accepting this in psychiatry, frankly, and other medical specialties don't, but that there are some patients that, unfortunately, despite our best efforts and the patient's best efforts, are not going to have a full remission of symptoms or a significant clinical improvement. And so what can we do to meet that patient where they're at and improve their quality of life, right? Whatever that looks like for them. And I think that can look a lot different for different patients.
Yeah, I agree with that.
Dr. Adams, this is a very rapid review of functional neurological disorders. I think we just hit the nuts and bolts, which is kind of appropriate for our bootcamp level. Any topics we haven't covered that you think we absolutely must talk about in order to do this justice at the bootcamp level?
No, I don't think so. I think if I could empower people listening to this podcast, that FND, I think, I don't know, to me, before I learned about FND, I first worked in an FND clinic when I was a fellow. And I remember thinking, oof, these patients are so complex and no one wants to deal with them or take them into their clinic. And in reality, this patient population is really fun to work with. You see a lot of patients get better, and maybe it's not like a total 180 back to the way that they were functioning before, but it can be very rewarding, I think, to see these patients and see I got back to work, or I got back to work in some capacity, or I'm feeling much better. So I think it's a fun group of patients to work with. I also work in the psych emergency room, and when patients with FND come through the doors, you can hear all the residents and all the trainees start going oh, we don't want to see this patient. It's going to be such a disaster. But again, I think we can actually make quite a big impact on these patients' lives. It's not rocket science. We all have the skills to do this. It's just a matter of approaching it the right way and looking for those being fluent in clinical rule and signs and looking for them. And again, I think psychiatrists can do this. We can do a neurological exam and find these clinical rule and signs. So hopefully you feel less scared. I like the Voldemort analogy because I think it is true. We're scared of what we don't know, but you can learn FND care and you can do it and you can improve these patients' lives.
I almost gave you trouble earlier that you are a psychiatrist who actually touches your patients. You actually examine. You're not worried that you are going to poison the patient with your transference if you are actually examining the patient. So respect there. I think most consult psychiatrists probably are at least familiar with a limited neurological exam. But I think that's a really important point. We miss that. And this is a diagnosis. And I think what you're saying when you're talking about how these patients can be complex, but they do get better, you're building a relationship with these patients, it sounds like, in clinic over time, right? Because these patients are so misunderstood, because even when they go to the best academic medical center in the country, the residents are a little bit nervous, a little bit scared. The patient can feel that. The patient can feel that the doctor doesn't think they're going to get better and nobody can explain their symptoms. And so when they do come to someone that says, actually, we have a name for this, we can treat it, and I'm going to be with you as you're getting better, if you get worse, I could see where that would certainly be a very rewarding population to see. My final thought would be, I think that functional neurological disorder stands out to me amongst other psychiatric disorders in that the patient resources seem really robust. It feels like there's a lot of good, high quality information out there to help patients get better. You mentioned neurosymptoms.org. We're going to link that in the show notes. Any other major resources that you're sending patients to all the time or that you're having your residents look at?
Yeah, neurosymptoms.org is wonderful. And what I tell patients is, I don't trust everything you read online. And so this is a website that was created by physicians. It is reputable. We feel confident in it. There's a ton of information on there. Other helpful websites there's fndhope.org, which is helpful for clinicians, also helpful for patients in terms of support groups and can they connect with other people who are going through something similar. There's the FND Society, which is free for trainees to join. And so this is a fascinating group. It's interdisciplinary. So the conference happens every 2 years. It will have physicians, physical therapy, occupational therapy, social work, but then they also have patients who are a part of the society, which is pretty cool. So at one of the conferences, they had a patient give a lecture on what it was like to be misdiagnosed, finally get the diagnosis, what it was like to improve from the patient's actual perspective. So it's a cool society. In terms of other resources, there are some helpful workbooks. The CBT workbook that we use, if we can link that, is called Overcoming Functional Neurological Symptoms: A 5 Areas Approach by Williams. There was also another recent smaller workbook that came out called Reset and Rewire. It says kids and teens on the workbook, but I tell patients we use it and we're recommending it to all patients of all ages. That one tends to be a little bit more image heavy than the Overcoming Functional Neurological Symptoms workbook. So sometimes it's a nice stepping stone of this was easier to understand and now I'm going to expand upon it and go into that CBT. The Overcoming Functional Neurological Symptoms is a CBT workbook.
Wonderful. Well, if we have piqued your interest with this rapid review, we will link all of those in the show notes. And Dr. Adams, thank you so much for coming on Psychiatry Bootcamp.
Awesome. Thanks for having me.
Thanks for listening to this episode of Psychiatry Bootcamp. If you enjoyed the podcast, please take a minute to leave a review on Apple Podcasts or a rating on Apple or Spotify. You can reach me at psychiatrybootcamppodcast@gmail.com. Find me on TikTok or Instagram at Psych Bootcamp. Our theme music is by Cave Radio. Special thanks to Matthew Braddock for production support. The opinions shared on this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice. This is a human content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.